Welcome to today's webinar, Long-Term Treatment Considerations for Patients with Severe Burns. This webinar is hosted by Medical and Life Care Consulting Services, case management and nurse consulting firm headquartered in Massachusetts. We're excited that you've joined us for this presentation. My name is Gigi Liggins and I'm the moderator. To kick us off, I'd like to introduce our speaker, Cindy Fleury. Cindy Fleury is presently the Director of Education and Professional Development for Medical and Life Care Consulting, and also serves as a nurse consultant and expert witness for medical-legal cases. Cindy has over 30 years of case management experience within workers' compensation and has supported hundreds of medical-legal cases with injuries and illnesses ranging from failed back injury, burns, severe traumatic brain injuries, and spinal cord injuries. Cindy is a registered nurse, certified nurse case manager, and a certified nurse life care planner. Cindy presently oversees the Northeast region of MLCC nurse case managers and works to ensure the highest quality of care is provided to patients while supporting a safe and timely return to work. Prior to joining the MLCC team over 12 years ago, Cindy worked for Pioneer Spine and Sports Physicians as a workers' compensation specialist and manager, ensuring efficient implementation of an individual's treatment plan, coordination of care through multidisciplinary communications, and safe and timely return to work. At this time, Cindy, I'll pass it over to you.
Thank you, Gigi. So what is a burn? A burn is a damaged tissue brought on by heat, chemicals, electricity, radiation, or the sun. Nearly 500,000 people in the U.S. seek medical treatment for accidental burns each year. More than 300 children a day receive emergency treatment for burns. If left untreated, burns can lead to infection. Types of burns. First-degree burns, they are mild, like a sunburn. The top layer of the skin, which is the epidermis, turns red and is painful, but doesn't typically blister. Second-degree burns involve the outer and underlying layers of the skin, the epidermis and the dermis. They are usually painful and cause redness and swelling and blister. Third-degree burns involve all three layers of the skin, the epidermis, the dermis, and the fat, which is the hypodermis. These are full-thickness burns. The hair follicles glands are destroyed. They may damage the underlying fat, muscles, tendons, and bones. The nerve endings are also damaged, therefore the burn area is not painful. However, there may be feeling of pain adjacent to the burn. Burn skin may be black, white, or red, and leathery in appearance. Third-degree burns can be life-threatening. How are burns classified? First and second-degree burns that cover less than 10% of the body are considered minor and rarely require hospitalization. Second-degree burns that cover about 10% of the body are classified as moderate. And third-degree burns that cover more than 1% of the body are considered severe. What's the initial treatment for burns? A first-degree burn, typically you just run some water over it, cool water, and it's like a sunburn, you just apply some aloe vera gel. A second-degree burn, antibiotic ointment or creams to prevent for second-degree burns. These ointments and creams can keep the wound moist and prevent infection. Daily dressing changes may be needed, which can be painful. Third-degree burns require fluid resuscitation if the burn is more than 20% of the total body area. Intravenous fluids, massive amounts are needed to maintain blood pressure and prevent dehydration and shock. Treatments include debridement or removal of dead tissue within 96 hours. This decreases the risk of infection. Skin grafting does not occur until the swelling goes down. Skin grafting replaces damaged tissue with healthy tissue from an uninjured part of the body. This is the donor site, which typically heals on its own. The donor site is like a second-degree burn. If there's not adequate skin available for grafting, a temporary graft can be used from either cadaver or an artificial source. However, these will eventually need to be replaced by the person's own skin. First and second-degree burns will heal in about 2 to 3 weeks. Third-degree burns require more long-term care that may last a lifetime. What are the different types of skin grafting? The choices between full and split thickness skin grafts depends on the wound condition, location, thickness, size, and aesthetics. A split thickness skin graft includes the epidermis and a portion of the dermis. They are used to cover wounds that are too large for full thickness skin grafts. They tend to shrink more in the wound bed, so they are not suitable for highly visible areas such as the face. Meshing a skin graft expands it to increase the area that it covers. A full thickness skin graft can be used to reconstruct smaller areas and are frequently used later in recovery for reconstructive surgeries of tight scars. These areas include those around the eyes, mouth, and fingers. Full thickness skin grafts consist of both layers of the skin, the epidermis and the dermis, and shrink the least compared to other grafts. The donor sites of full thickness skin grafts are generally closed like a surgical incision. Sheet grafts are generally applied to the face, neck, hands, and feet to improve appearance and reduce skin tightness over time, but may require more skin to cover the area and require greater immediate care with close monitoring to be successful. A sheet graft uses the whole piece of skin without adding holes to allow the wound to drain. Skin grafts can fail if there is too much fluid trapped underneath. They may use larger sheet grafts with children or to minimize graft contractures in exchange for a larger donor site. Newly healed grafts are very fragile, and precautions should be taken to avoid bumping, rubbing, or scratching them. Mesh grafts are often used for less functional, less cosmetic areas and for larger wounds. To cover large areas, the team puts the donor skin through a machine that makes small slits or holes in the skin, which creates a mesh pattern that can expand the graft. This stretched skin covers a larger area than an unmeshed sheet graft, but it leaves a permanent mesh pattern. The wound heals as the area between the mesh skin graft and the holes fill in with new skin. This may take days or weeks. The wound doesn't need any dressing once the mesh sheet starts to stick to the skin and the drainage stops. The wound should be moisturized daily. Allograft versus an autograft. What's the difference? An allograft is a temporary artificial or cadaver skin. This is used to prevent fluid loss and infection. The body will reject this, so it must be replaced with the patient's own skin, which is an autograft. An autograft is the patient's own skin taken from a donor site, which is a non-burned area. The donor sites can be used over and over again. Once the area heals, you can go back and take more. Smoke inhalation can be a complicating factor of a burn injury, which may result in suffocating the body with carbon monoxide, poisoning the body with toxic chemicals, damaging the windpipe, breathing passages, and/or lungs from toxic chemicals, burning the mouth and throat from hot gases. Most patients do not suffer long-term respiratory impairment following smoke inhalation. However, although rare, residual long-term sequelae may include tracheal stenosis, bronchiectasis, interstitial fibrosis, reactive airway disease, and bronchiolitis. What are the potential complications associated with burns? Arrhythmias and abnormal heart rhythm. These can range from harmless to serious, requiring treatment. Dehydration, which can lead to organ failure. Disfigurement, scarring and contractures. Edema. Compartment syndrome due to massive swelling. Escharotomies may be needed to release the pressure and restore blood flow. May need to perform fasciotomy to save the muscles if escharotomy is not enough. Organ failure due to dehydration. Hypotension that can lead to shock. Severe infection that can lead to amputation. Post-traumatic stress disorder, anxiety and depression. sleep disorder, chronic pain, hypersensitivity, sexual issues, acute respiratory distress syndrome as a result of systemic inflammation, fluid resuscitation, protein loss, prolonged mechanical ventilation, and multi-organ dysfunction. Addiction. There's a high rate of addiction due to the heavy use of medications early on. Lymphedema due to the destruction of the lymphatic system, doesn't drain properly. Excessive swelling in the uninvolved areas. Dermis contains sweat glands and scar tissue does not have any sweat glands. So the uninvolved areas develop compensatory glands to accommodate. This may lead to pooling of sweat around normal skin, which can lead to excessive sweating. Consider wicking clothing when doing your plan. Hypertrophic scarring is raised scars in the area of the original burn are the most common complication of a burn injury and can limit the survivor's ability to function as well as affect their body image. It is difficult to predict who will develop scarring. Research shows that less severe burns that heal in less than 14 days generally have no scarring. More severe burns that heal in 14 or 21 days are at risk for scarring. Burns that take more than 21 days are very high risk for scarring and may require skin grafting. Compression garments can prevent the development of hypertrophic scar formation. Hypertrophic scars can cause a lot of problems. What are the problems associated with hypertrophic scarring? Scars across joints can cause a decrease in the ability to move. These are called contractures. People with visible scars may feel self-conscious and avoid social situations. This can lead to isolation, depression, and lower quality of life. Scars can be dry and result in cracking and breakdown in the skin. They are sensitive to the sun and chemicals, excessively itching. Contractures can affect the ability to move and take care of oneself. If the contracture involves the lower extremities, it may result in difficulty squatting, sitting, walking, or climbing stairs. If the contractures involve the trunk and arms, one may have difficulty with grooming, eating, dressing, and bathing. Some contractures are unavoidable, but many can be prevented with active involvement in the rehabilitation programs. There are treatments for hypertrophic scarring. There's no single treatment that is ideal for treating scars. For many years, compression garments were thought to be the best treatment for hypertrophic scarring. Custom fit garments may also be useful for decreasing post-burn itch and scar formation. Custom pressure garments should be worn 23 out of 24 hours per day. Even though the use of pressure garments may not improve the scar, they can decrease itching and protect the skin from injury. Some burn survivors feel that the pressure garments look better than the scars themselves. Silicone gel sheets are pieces of thin, flexible, medical-grade silicone that are placed over the scar and may decrease itching and dryness. They are generally durable and comfortable to wear. They can be worn alone or underneath pressure garments, splints, or cast. The therapist may recommend custom-made inserts to be worn under gloves, compression bandages, and custom garments to increase pressure on the scar and improve healing. Massage can help soften and desensitize the scar. When combined with stretching, massage can make the scar looser, softer, and more comfortable. Surgical treatments such as contracture releases to loosen the scar and improve motion. Laser treatment to thin the scar tissue, improve its appearance and flexibility of the tissue. Kenalog injections may be used in conjunction with laser treatment. During laser treatment, beams of light are used to either remove scar tissue or poke holes in it, depending on the type of laser used. Both methods stimulate the production of collagen and allow the body to create new, smoother skin. After the treatment, the scar should appear lighter and less noticeable. Kenalog injections may be performed simultaneously to reduce inflammation, flatten, and lighten the scar. Patients with severe burns will most likely require a combination of treatments and require multiple procedures to achieve satisfactory outcomes. Itching can be a big problem with burns. Burns can damage and destroy the oil glands that normally keep skin from getting too dry. Partial thickness burns have few oil glands, and full thickness burns or skin grafts have no oil glands. The lack of oil glands lead to dry skin. The chaotic organization of collagen in the healed skin may trap nerve endings, which also contributes to the itching. Many patients experience intense itching after their burns heal. Studies have shown that the larger the burn, the more likely that itching will be a problem. Moisturizer should be applied frequently. Moisturizers with high water content, such as those in a bottle, generally soak into the skin faster and will need to be applied more frequently. Moisturizers that come in a tube or a jar generally are thicker and have less water, so they need to be applied less frequently. Unscented and fragrance-free moisturizers should be used. The approaches for itching are varied. Keeping the skin moist is the starting point. Also, massaging and pressing down firmly on the scar may help. Scratching increases inflammation and will make itching worse. Custom pressure garments may also help with itching. Medications such as gabapentin or Lyrica, which are commonly used for nerve pain, have been shown to be the first-line medication for itching. Antihistamines may also be helpful. Mineral oil, Vaseline, or antibiotic ointment should never be used to moisturize the skin. These can lead to allergic reactions and skin breakdown. Sun exposure. Exposing the healing scars to sunlight should be avoided. Scars that are discolored and have not matured burn easily. If going out in the sun, it's recommended to plan activities in the early morning or late evening when the sun is least intense. Apply sunscreen with SPF of at least 30 and wear protective clothing. What are the long-term treatment considerations for burns? Physical and occupational therapy to maintain joint mobility and improve function. Stretching frequently, casting or splinting may be used to help position the scar area in a stretch position. Physical or occupational therapy should be considered following interventional procedures to include range of motion, splinting, and/or massage. Massage therapy to facilitate lymphatic drainage or keep tissue or deep tissue massage to free up tissue so it glides better. Compression garments, silicone sheets to reduce itching. Surgery for scar revision or contracture releases. Laser treatment and catalog injections to treat hypertrophic scarring. Psychological counseling may be needed to address anxiety related to the accident and assist with coping, especially with disfigurement. Treatment for addiction may be needed. Wound clinic evaluations and treatment may be needed due to skin breakdown or non-healing wounds. May include dressing supplies or visiting nurse services to oversee wound care. UV protective clothing, hats and lotions, moisturizers to reduce dryness and itching. Are there mobility issues? Are home modifications or home care needs needed? A stair lift if they're having difficulty climbing stairs. Is assistance with ADLs and IDLs needed? A walk-in shower or aids for assistance for safe personal care may be indicated. DME to promote safety and assistance with ambulation. Are they having trouble with long distances? Consider a scooter or a wheelchair. Temperature regulation can be a problem with severe burns affecting large areas. Consider thermal and/or cooling clothing, depending on the patient's geographical area. Long-term medication needs, neuropathic medications to address neuropathic pain, antihistamines to reduce itching, wicking clothing to remove excessive perspiration, dermatology visits to evaluate for skin changes due to increased risk for skin cancer. They will require frequent visits with specialists. If there was respiratory involvement, they may need a pulmonologist, PFTs, oxygen, respiratory treatments. Treatment considerations should be individualized depending on the area affected, as well as the extent and severity of the burn. If the burn affects joints of the lower extremity, there may be mobility issues. With the burns affecting the upper extremities, they may need assistance in the home with bathing, dressing, meal preparation, home maintenance. Surgery for contracture releases may be needed in conjunction with therapy to maintain joint mobility. For pediatric patients, you must take into consideration growth and development. Some patients require extensive surgical intervention and multiple procedures. I'd like to share a case study with you. We recently did a life care plan on a woman She was a 50-year-old woman who suffered 65% total body surface area third-degree burns. She was wearing a respirator, so she didn't have any difficulty breathing. Burns were present to the neck, right torso, and all extremities. 70% of her burns were full-thickness burns. Although there were no acute airway issues, intubation was needed for core central line access and extreme pain. A central line and an A line was placed for constant blood pressure monitoring. She required large volume resuscitation, 1 to 1.5 liters per hour, and pain control with fentanyl. She underwent multiple surgical procedures, received DVT prophylaxis, pain management, cardiac monitoring to control blood pressure and heart rate, frequent dressing changes, psychiatric evaluation and counseling, enteral feedings and nutritional assessments to ensure adequate caloric and protein intake, occupational and physical therapy. She remained hospitalized for over 2 months, and then she was transferred to an acute rehab for continued care and stayed there for an additional month. Following her discharge, she continued to undergo frequent visits with a plastic surgeon and underwent multiple surgeries and extensive therapy. Her complications included acute blood loss anemia, acute kidney injury, hyperkalemia, proteinuria, hypernatremia, hypoxia due to fluid overload, MRSA line infections, pneumonia, bacteremia, chronic depression, vitamin D deficiency, stress, anxiety, fatigue, insomnia, hypertension, subcutaneous mass on her neck, pruritus, hypertrophic scarring, chronic pain, neuropathic pain to her bilateral lower extremities, hypersensitivity to her upper and lower extremities, mood disorder with depressive features, left hand and wrist volar contractures, left ulnar fifth digit contractures, left upper extremity contractures, heat and cold sensitivity, and bilateral arm contractures with pronation and supination. She underwent a total of 25 surgeries from the date of her injury until February of 2023, to include escharotomies, multiple debridements and grafting, incisions and contracture releases, laser treatments, with more surgeries anticipated in the future to release contractures due to scar tightness and decreased motion. So what did we put in her plan? Due to the significant involvement, we put in some yearly occupational therapy for splinting and for home exercises, some periodic physical therapy to the potential of complications due to persistent pain, swelling, and decreased mobility, massage to promote lymphatic drainage and myofascial releases. Specialist appointments included dermatologist, pain management, frequent visits to the plastic surgeon, psychiatry and psychology, wound clinic visits to address any breaks in the skin, and oversight with her primary care physician. Diagnostic testing included routine blood work to evaluate for complications such as infection or organ toxicity due to long-term medication use, included vitamin D levels due to lack of sun exposure, and x-rays of her hand due to the degree of involvement and need for future surgeries. DME included support stockings due to edema, cooling and wicking clothing, thermal wear, sun protective clothing, and lotions, dressing supplies, mobility aids for community use, such as a scooter and wheelchair, specialty mattress, and custom wheelchair cushion to prevent skin breakdown. Although she was ambulatory, she was limited by her endurance and her tolerance. Medications for pain and itching, vitamin D supplement due to lack of sun exposure. We did include some home care services to assist with home maintenance and personal ADL care, periodic skilled visits for wound care and assessments, orthotics for splinting postoperatively, including potential future surgeries recommended by her treating physician. And that's it. That's all I have.
Thank you so much, Cindy. I am sure that our viewers have really attained a wealth of information about severe burn injuries. With that, we will conclude this webinar, but do invite you to reach out at any time if you have a question about a case. Our consultations are always complimentary. You can also learn more about our services by visiting www.medicalandlifecare.com. We provide comprehensive life care plans, life care plan projections and medical cost projections, medical chart reviews and chronologies, Medicare set-aside allocations, focused estimates of care, and legal nurse consulting. Again, Cindy, I want to say thank you, and to our viewers as well.
Thank
Bye
you.
for now.